All right.
So hi everyone, it's Nina Collins, and I'm here at the Wolfer. We're interviewing today Dr. Leslie Meserve, who is a chief medical officer and the co-founder of a telemed company called Curie MD. And telemedicine has been something that's been in the air and people are starting to use over the past couple of years. I've used it a couple times myself, but it's very new. And now with the COVID crisis, it's something we're all suddenly familiar with. We're doing everything via Zoom. So it's a good moment for these startup companies. And I'm very happy to have you here today. Welcome.
Thank you for having me. I'm excited to get to be here. Spend
Yeah.
some time chatting.
Yeah. So Leslie's in California. And as I said, you're the chief medical officer and co-founder of Curie MD. Can you tell me a little bit about your background and what led you here?
Sure. So I'm 45 years old, and when when I started my early 40s, something really started to shift. And I really realized that at that point, um, I'm really the only person that has control over my life and my career and my health. And I decided that I really wanted to take control of that. I realized that life is short and that, there's really no time for me to be unhappy or for life to be suboptimal. So I
Mm.
was a primary care physician. Yeah, go ahead.
No, it's a very good aging revelation, right? I mean, I think it's something we
Yeah,
all hopefully come to in our 40s or 50s,
that's
and
right.
that kind of taking ownership. And I think that ties to a lot of things. Like I always feel very clear the idea that knowledge is power is
Yeah,
so true,
yeah,
and that we are responsible for the most. There are things we can't control, but there are a lot of things we can control.
absolutely. Absolutely. And at the time, I was a primary care doctor in a very busy concierge practice, pretty
Mhm.
much running myself ragged, working nights, weekends, kind of on call all the time. And I was also starting to notice some changes in my body. I've studied both traditional Western medicine and naturopathic principles. And, I know that the pillars of health are exercise, sleep, nutrition, and hormones.
Yeah.
Yet I really wasn't doing those things for myself. And so I started a kind of my own journey to get myself back into a healthy place. And at that time, discovered an organization called the North American Menopause Society. If you're
Oh, I know
familiar with
them.
it.
Yeah, I quoted them a ton in my book. They're super
Yes,
helpful. Yeah.
so helpful. And it's just so heartening to know that there's an organization of clinicians and researchers and specialists whose goal in life is to educate us about what happens to our bodies in midlife and how to treat them, what
Yeah,
works and what doesn't work.
right. And you wouldn't even know that this organization exists if you go see your regular doctor because people just
No.
refer you to them. May I ask what kind of symptoms you were having?
Yeah, I was starting to feel hot flashes and night sweats. Still cycling, but I was noticing them more and more. And had never had those in my 30s.
Yeah.
And also was having some pain with intercourse. And so, those things led me to try to figure out what I could do. And I had to actually seek out several people to find one person who could help.
And
Um,
you're a primary care doctor.
I am.
So these were things like, I mean, the one thing that I've really learned through our community that is kind of a shock to a lot of women is painful intercourse and
Yeah.
vaginal atrophy. And people really don't talk about it when it comes as a shock. So it's amazing that it came as a shock to you. I mean, you'd not heard
Yes.
about it in medical school. It was not.
I knew about it, but it's not until it affects you that you
Yeah.
realize, yeah,
Yeah.
just how much it affects life.
Yeah.
And, that's an important part of a relationship. It's not the only part, of course, but it's a really important part. And it was very important to my husband and to me. And I was bound and determined to find a solution for that. And I
Mhm.
wanted to sleep really
Right.
well. So between those two things, I kept looking.
Yeah. So what happened? You saw a few different doctors, and then who finally helped you?
So there is a gynecologist in our town, Dr. Stephanie McClellan, who's absolutely fantastic. And she worked with me and helped me come up with some different solutions. I also worked with a pelvic floor physical therapist. And a lot of
Mm,
people don't even know that that exists.
yeah, we
But
talk about that a lot in our community. Huge.
yes,
Yeah.
huge, huge. That plus some addition of estrogen and some changing of my hormone products
Uh-huh.
was what worked for me.
Uh-huh.
And so through that journey, I decided this is what I want to do. I want to be a menopause specialist. And
Right.
so I took what I've learned from my training in primary care and then became a certified menopause practitioner. And then when my co-founder came to me and said, do you want to do what you're doing and then take this to a larger audience and be able to do this on a larger scale and help more women? I said, of course, absolutely.
All right.
How do we do that?
And when was that? How long ago was that?
It was about a year ago.
Okay, so
Yeah.
this is a startup telemedicine company. And I should interrupt for a sec just to say, I think your story is so typical. And again, it's upsetting because you're an actual physician. But one of the reasons I'm really excited about telemedicine for menopause is I think it lends itself really well. I think there are women all over the country who live in places like in New York or LA. It's a little easier to find a menopause specialist. But if you're in a place like North Dakota or New Mexico or probably, Ohio, all sorts of places, I think it's actually super hard to find someone who really knows. Because when I went to the doctor, I always tell this story. When I went at 44 with my first symptoms of insomnia, my primary care doctor, who I love, her name is Ina Gort, she's my age, I think she's terrific, but she really offered me birth control pills and antidepressants. Like that was her answer. And she didn't ask if my, vagina was hurting, or she really, and she was my age, like it was mystifying. And so I think telemedicine makes a lot of sense for this because it's not something you really need to be seen physically for. What you really need is someone to listen to you and understand where you are. I mean, you should probably get your bloods analyzed every so often, and that can be done at a lab and then shipped. But you really need someone to just talk about your sleeping, your anxiety, your all the million symptoms that you might be having.
That's
so
right.
anyway, so tell us about CurieMD. So it's a startup, it's a year in, and what do you guys do?
Yeah. So we are an online virtual health clinic with a mission to modernize menopause. And we're able to not only educate women about what's happening with their bodies, but also to be able to connect them to healthcare providers who can help them with those symptoms. We're kind of an end-to-end product. So women fill out a form online with some general symptoms. If they're a good candidate and they're in California, we launched in January. The plan is to expand to multiple states, but right now we're just in California.
Okay, and so just for listeners, you should know, so CurieMD hopes to expand to other states. This is definitely, this is a little bit of a trend, the telemedicine menopause. There are a few companies out there doing this, so it's going to be interesting to see how it all evolves.
Yeah.
So this is interesting for everyone. And then the Wolfer members who are California residents are actually going to get an opportunity to have a free consult.
That's right.
So go on.
Yeah. So, we try to make it mimic what happens in a real doctor's office as much, not a real, but in a brick and mortar doctor's office visit. We do a history. So I listen to you and our other healthcare providers listen to you. We talk about what your symptoms are. And if you are a good candidate for it, what we do is we talk about the different types of options that we have, the different hormone products or non-hormone products. If one of those fits for you, you work with a national mail order pharmacy, and they deliver, if it's a hormone product, we use Bioidentical, FDA approved medications, and they're delivered to your door. And then what we do is we do like to make sure, of course, that we obtain patients' labs and mammograms. That's what I do in my brick and mortar practice, and that's what I do in my telemedicine practice as well. And we make sure we do a follow-up visit in 3 months to make sure we're right on track. We're available for, of course, when things come up, if there's a question or a concern, we're here to answer those questions. But it's been really fun to get the feedback from patients who are coming back in for their 3-month checks, and they are happy. They are not sweating all night long. They are, they're living their lives. Their husbands are like, oh my gosh, I feel like I have my wife back.
Yeah, no, the difference when you have good menopausal, perimenopausal care is huge. I went through a really horrible period. I resisted taking hormones for a long time because my mom died of premenopausal breast cancer at age 46. And so I was really worried about it. And then finally last winter, 2 years post period, I started having really crippling hot flashes. Like I couldn't function, I couldn't sleep, I couldn't work. I was so exhausted all day long. And I went on the patch, and it's like life changing. I mean, when you really need it, it's really like, I mean, I now I sleep like a baby. It's fantastic.
It's like the lights go on again, and you can feel, for some women who have a sense of, depression's not the word, but a depressed mood, a sad mood, or a tearful mood. It's like the lights come on and they are pulled out of the darkness even.
No, it really
so, yeah, I know. And it's hard, you say, well, why can't patients get this? I get this question all the time. Why can't patients just get this from their regular doctor? And all I can say is it's just not in our training. As a primary care doctor, I got close to zero training in menopause. And even OBGYNs, 20% of them, there are only about 20% of them who actually get formal training in midlife care, menopause care.
Yeah, I hear this all the time. I mean, it's infuriating. What's the
Yeah.
number of women over 40 in this country? I can't remember it offhand, but it's gigantic.
50 million, I
Yeah.
believe. Yeah, it's
Um,
huge.
and I mean, hopefully this will start to change, and maybe this movement of telemedicine for menopause will help it change. I have so many questions for you. So wait, I want to back up for a second. So users pay by visit, right? It's not a membership thing. You just
That's
pay
correct.
as you go. And how much is is there a range for what visits cost?
Yeah, it's $39 for up to 20 minutes, and we can accomplish a lot in 20 minutes. Yeah.
Right. That's
And
great.
then
That's so reasonable. My God.
yeah, and the medications run anywhere from $33 a month to $100 per month. And I always tell women, most of the time it's close to what your copay is going to be at your pharmacy. And also consider it an investment in your health. I mean, this is an investment in living your best life. And you got to do what you got to do, and you have to
No,
advocate for yourself.
that does seem commensurate with what your copay is. I mean, for my hormones, and when I was doing Vagifem, I was paying $50 a month, which was really annoying because Estrace was, I think, almost free. But anyway, yes, you
Yeah.
end up paying. And let's talk for a minute about the difference about HRT, because one of the things that's interesting to me here is, HRT was hormone replacement therapy was hugely vilified for a long time. I think a lot of us know that it was very popular. Then there were big studies that linked it to breast cancer and increased chance of heart disease. And now in recent years, fortunately, there seems to be kind of a coming to the middle thinking about HRT. I think a lot of the really horrible studies have been disproven. It's certainly clear that for certain women, like if you've had breast cancer or ovarian cancer, you should not be on hormones. But my understanding is that the current thinking is that if you do it earlier in menopause and for a limited period of time, it really is fine. And I've even read some things that say it may be beneficial for things like Alzheimer's. And so I think it's great that women no longer I mean, I felt guilty when I first went on hormones. Like I really was like embarrassed and kind of ashamed. And so I would just love to hear your take on hormone replacement therapy. And I'm also wondering, I mean, I guess your company is new, but I'm wondering how many women who come to you are treated with pharmaceuticals versus non-pharmaceutical intervention.
By the time they get to us, most of them have tried over-the-counter products, and they've tried cooling measures. I spoke to a woman today who was delightful, but walked around her job with her fan in her hand, like a little portable electronic fan. And she's like, people tease me. She's like, but I'm coming out of my skin if I don't have this fan on me at all times. By the time they get to us, they're really ready for some treatment. They want the best treatment. And we know that hormone therapy estrogen is what works for hot flashes. It is proven to be the very best treatment for vasomotor symptoms, hot flashes and night sweats. But to answer your question about safety, I mean, I always start off with any conversation with a patient and I say, I'm never going to tell you that anything in life is risk-free. There is absolutely nothing risk-free, and this is not either. So there are risks to any decision that you make, but there's also a risk to choosing not to be on hormone therapy. So let's talk about what the risks are if you choose not to be on hormone therapy. Now, I know there's some people that cannot be on it, but let's say you elect not to use estrogen. What you're doing is you're allowing your bones to become weaker. That's one of the biggest effects that we know is a benefit of being on estrogen, is that it preserves your bone strength and your bone elasticity. So I know that's not a sexy topic, but your 75-year-old self who falls down and does not break a hip is going to thank you for being on your estrogen so she doesn't end up in the hospital with surgery. And keep in mind that having a hip fracture is not a benign entity for many patients.
No, it's the beginning of the end for a lot of people.
25% of people die within a year of a hip fracture from complications and what have you. So choosing not to be on hormone therapy is a choice to perhaps allow cardiovascular disease to occur. So we know that women who start estrogen within the window, so the window of time is what you were talking about. So within 10 years of menopause and before age 60, we know that women who start then have a lower risk of cardiovascular disease. And your point about Alzheimer's, yes. I mean, they're not randomized controlled trials, but observational studies show, there's 4 large ones, show that women on hormone therapy have a lower risk of Alzheimer's disease.
Which is huge, because I think women have something like 4 times greater risk of getting Alzheimer's than men, or 3 times, some huge
Yes.
number, right?
Yes.
Um,
And they have a 7 times higher risk of dying from heart disease than from breast cancer. But let me address breast cancer because that is what everyone's fear is. And it's because in 2002, the Women's Health Initiative released some claims, some press releases prematurely, and the media sensationalized it. And fear lives very deep in our brains, and the amygdala, it's very hard to remove fear. And so if you develop a fear of something, I mean, it makes sense. If you learn that a red berry is dangerous, you should never forget that that red berry is dangerous or that a tiger is dangerous. So it's smart of our brains to do that,
Yeah.
but it's really not helping us in this instance. So in the worst case scenario in the Women's Health Initiative, now this was a study of synthetic progestin and a synthetic version of estrogen. Okay, so which is not what we're using. We're using bioidentical, but let's talk about that. This worst case scenario. In the arm of the trial where women received estrogen plus progestin, there were 38 breast cancers out of 10,000.
mhm.
And in the arm where they received a sugar pill, there were 30 out of 10,000. So there was a difference of 8
Mhm.
out of 10,000.
1,000.
And so I just tell patients, and some of them will look at that and they're like, too much. But most look at it and say, gosh, a 0.08% increased risk, that doesn't seem like that much to me. And I
Right.
tell them, that's the same amount of risk that you take on if you drink alcohol every day, or you become overweight, or you don't exercise every day.
Or you cross
And
the street, or
or going
yeah,
to the grocery store,
yeah,
right? So
yeah,
right now that's even considered dangerous.
right, exactly.
And there are things in life that we do so that we live long and well. And we just have to remember the balance. Is the benefit greater than the risk? And if the
Right.
benefit of heart disease, Alzheimer's disease, bone health, if all of those things to you are more important than this, theoretical risk of 0.08% with a synthetic estrogen and
I mean,
progestin.
the problem is, of course, we're all going to get something eventually. I mean, if I
We
get
are.
breast cancer in the next few years, will I think it was linked to the hormones I took? I think it really is a very individual decision, and I think it does often come down to quality of life. Like
It does.
I reached a moment where I was really so miserable, and I'm so much happier now, and
Yep.
this is what I'm doing. And then, of course, there'll be the tricky thing of, I don't really know. And it's amazing. I've been running this group now for almost 5 years, and I don't know the answer to this either. But like, I don't know when I'll go off it. I don't know how, like, because I'm afraid I'll go off and then you don't know, are the hot flashes still there? Are they not there? I figure I'll do it for a year and then maybe I'll test and go off and see. I think because it's so different for everyone, right? I mean, I meet some women who say they still have hot flashes in their 70s.
And their 90s. There are
Ugh.
some in their 90s who cannot come off of estrogen. And it's an individual decision. And so, but just remember that when you stop the estrogen, your bone strength
Yeah,
starts
no,
to
that's a good,
decline.
I mean, the bone strength, the cardiovascular, the Alzheimer's, I mean, these are all very good reasons to be on it and make me feel like it's, it's a reasonable thing. I'm going to check in a sec to see if we have questions, but
Yeah.
I just have so many other things to ask you about. So can you tell me a little bit about why you guys, and you are the chief medical officer, so presumably all the medical decisions that are made with Curie MD lay with you. Why did you go with bioidentical versus not?
There is a demand for bioidentical at this point. There is, the movement towards natural products, and everything that we take
Right.
into our bodies is real, and it's based on some very strong logic. I tell patients, as far as diet goes, nutrition goes, if nature made it, you can eat it.
Right.
If you can pronounce it, it's probably okay to eat.
That idea of staying on the outside of the supermarket, not
Yes,
in the middle.
yes,
Yeah.
exactly. Which I know doesn't always,
No, but
carry over to the practice of medicine. I prescribe lots of things that most people can barely pronounce. But we're mimicking exactly what the body used to do. Your ovaries used to make estradiol and progesterone. My ovaries are still trying to, but coming up short.
mhm.
So, we're just replacing what our bodies used to make enough of. And so women tend to tolerate it more. And so that's why we chose to use Bioidentical.
So why do some doctors still not use bioidentical? I don't really understand why there isn't. I feel like I hear about a lot of different variations of treatment all the time in HRT. People who have creams and, even the progesterone. Like I take progesterone every night, 100 milligrams, but I know women who only take progesterone 10 nights a month. Is that because they're in a different place in the process, the perimenopausal process? It just seems like there's no standard of care.
Well, in the perimenopausal timeframe, it is more complicated. So that's probably, that's
Mhm.
an hour-long conversation in itself.
Okay.
But for postmenopause, there is a very clear amount of progesterone that is needed to protect the lining of the endometrium. So if we take estrogen, it's unopposed
Mhm.
by progesterone, then we can get an overgrowth of that lining and you can get postmenopausal bleeding, and you don't want to have that overgrowth. So the
This
minimum,
sounds very bad.
it's you don't want that. Yeah. So the minimum progesterone by mouth is 100 milligrams at night,
Okay, that's what
and
I take.
then 200 milligrams for 10 days of the month. The cyclical progesterone works for many women. Some of them will still have bleeding, some with that program though. It's just, there's a choice. Some women just opt for that option. And
Okay.
then to address, creams versus, all the different things that are available. I know I love that we have options. That's fantastic.
Yeah.
I think one of your questions is, compounded versus FDA approved.
Yeah.
So a lot, I'm not saying,
Compounded for our listeners means bioidentical or no.
well, actually, no. And that's a
Okay.
common, misperception. So bioidentical means it mimics what the ovaries are doing.
Okay.
So, but you can get bioidentical either from compounded pharmacies or you can get it from FDA approved, large pharmaceutical companies. But
Oh.
bioidentical just means it's the exact chemical compound that is produced by your ovaries. But when you get it compounded, and I will tell you that we didn't always have the ability to get bioidentical estrogen from pharmaceutical companies, but now we do. And the
Okay.
nice thing about that is that you know what you're getting. It's always the same dose. It's highly regulated. So, that's why we chose FDA approved
Mhm.
bioidentical hormones.
Mhm.
Now, I do have some patients who don't do well with those kind of strict dosing guidelines that we get from the FDA. And
Mhm.
so for them, there is a nice option, which is compounded hormone therapy. And compounded just means it's made in a pharmacy, and it's tailored to you, and sometimes in different doses. It can be available in creams, patches. Well, I don't think they have patches, but creams and
Mhm.
lotions. And the good side is that the dose can be changed in very finite levels.
Mhm.
But the downside is that you can have some batch to batch variability.
Okay.
So the North American Menopause Society suggests strongly that women try FDA approved medications first. And if
Okay.
they can't find what they need from that, then move to compounded. So does that
Okay.
answer the question?
It does. I mean, what it all makes me really think, it really illustrates the point that most doctors, certainly primary care doctors, and most gynecologists are not this informed on these subjects, and it's complicated. There's
It's
a reason
complicated.
the menopausal women consumers are confused by it because
Yes.
there are a lot of different options and it's not entirely clear, and it seems like each woman's needs are slightly different. Like even this conversation is going to make me go back and ask my gynecologist because I don't take a larger dose of progesterone at all. I only take 100 milligrams.
That's good. That's
And
fine.
so
Yeah.
maybe I don't need, but it's like, I feel like I talk to menopausal women all day long. I feel like I should at least have some of the, and I have some of the answers, but not all of them. So what it says to me is that every woman in menopause and perimenopause could really use one person who's actually just thinking about this aspect of their health. And it's very likely not going to be your gynecologist or your primary care doctor. If you're lucky, it'll be your
That's
gynecologist,
right.
but it's rare. You have to really live someplace where there are people who really know what they're doing. So it seems like telemedicine for menopause is a great idea, which is great. So can you tell us a little bit about the onboarding process with you guys? I guess you described it a little bit. People go online, they fill out some basic information.
That's
I
right.
assume they put in their credit card and they make an appointment, like on
Yeah, they don't even have to put their credit card in right away. They just book an appointment with me or one of our other healthcare providers, and then we have our 20 minutes, and I go through the a normal visit, and we talk about options. And there are some women who won't choose, what we have to offer, or they won't be a candidate for what we have to offer. But the minute, I would say a large percentage of them are giving it a try. And I always tell them, if you love it, awesome, keep taking it. If you don't, throw it away. And I always ask them to at least talk to me about it or talk to
Yeah.
us about potential side effects. But um, the benefit of giving it a try and seeing if it works, I mean, what have you got to lose?
Absolutely.
Yeah.
And you're also offering anti-anxiety medication, I assume, since
So
that's
we
a
do. So Effexor, venlafaxine is a medication that has been studied both for anxiety and depression and for vasomotor symptoms, hot flashes and night sweats, and it works very, very well for that. And so for women who are unwilling or unable to take hormone therapy for their hot flashes, yes, the venlafaxine works quite nicely.
Isn't Effexor, it's one of those drugs that's hard to come off of, isn't it? It's not like Prozac or Lexapro.
You do have to, with any of those, you do want to go off of them slowly,
Yeah.
because coming off of them quickly, you're right, well, it doesn't make sense. It's so easy to wean off. So I just
Mhm.
encourage patients to talk to me about when they want to wean off of them.
Mhm.
I've had patients describe it as feeling like the world is moving in slow motion, or they get a
Mhm.
headache, so if you
Yeah.
just go slow with the weaning process when it's time to come off, it's certainly doable.
I'm just curious. Yeah. And then other like antidepressants, like Prozac or Wellbutrin, what's your feeling about those?
Well, they're fantastic products. I almost think Prozac should be in the water right now
Yeah.
because everybody's so anxious. But they're great products. We don't happen to have those on our formulary, but they do work for. I don't know that Wellbutrin has been studied. Prozac has, Lexapro has, Effexor has been studied
I
for
don't
hot
understand why
flashes.
Wellbutrin hasn't, because sometimes Wellbutrin can help you lose weight, and I've sometimes thought
Mhm.
it'd be like the perfect menopause drug if it helps with
Right.
depression and weight loss. For some
I am
reason,
gonna I
not.
am gonna write that down. I am gonna see, because you're right. It's actually in one of our weight loss products.
Yeah,
Yeah.
it seems like a really good idea, but there must be a reason people don't do it, because you never hear about. I mean, you do hear about women taking Prozac, but anyway.
No,
But it's
I'm
good
assuming
you're
that's how it's
addressing
been studied. Yeah.
anxiety issues.
Yes.
Um, All right. Well, I think I'm trying to think of this. I mean, I really could talk to you forever because I find this subject super fascinating. We got one question early on, which I actually answered before we came into the call, which is what's the difference between perimenopause and menopause and postmenopause? Maybe you want to just quickly address that for any
Sure.
listeners, because that is a common
Absolutely.
misconception.
I know. So perimenopause is the time frame in life where your ovaries kind of go in and out of retirement. They will decide to show up to work for 6 months, and then they might retire for 2 months. And then they'll come back and they'll be regular. This isn't the same for every woman. Every woman has this roller coaster slightly differently. But for many women, it is kind of a lot of ups and downs as the ovaries near retirement. And what can happen during that time frame is they can experience a lot of the symptoms of menopause. So hot flashes, night sweats, vaginal dryness, decreased libido, but they're still menstruating, they're still having cycles. And so it's a little tricky because hormone therapy is a challenge during that time frame, because the ovaries do show up to work some days.
Right. And it's
Um,
constantly like
it's all over the
this.
place.
Yeah.
Yeah, it's a fun roller coaster. But birth control pills are one option. There's another option that we offer, which is progesterone during the second half of the cycle, which is great for women who have pretty severe mood symptoms
I've
right
heard
before
that.
their period. Yeah, so that's a nice option. Um, your last period starts um, is where we start counting. So when you've gone a year past your last menstrual period, that's when we know you have fully entered menopause.
Mhm.
Okay. And so once you've fully entered menopause is really kind of the best time to start hormone therapy. Although exploring it before then and learning about it does, I think, makes a lot of sense.
Yeah, and often in that perimenopausal time is when you experiment with things like you go online and you buy creams and you take remifemin and you take black cohosh, you kind of
That's
try
right.
everything.
That's right.
Yeah.
Yeah, but that's how you know is when you've gone the full year. And then postmenopausal, you're postmenopausal for the whole rest of your life.
Right. So you're only
Yeah.
really menopausal for a day, essentially. It's the anniversary. You're in menopause when you've hit that year without a period, and then you are postmenopausal.
Yeah, exactly. Exactly.
All right.
So yeah, and we've got tons of information online, as I know you do too, and we'd be delighted to answer any questions. If your listeners have questions later on and you want to send them to me, I'm happy to answer them.
We absolutely will. So everyone, it's Curie MD. We'll be posting about this. There's all sorts of information, but why don't you tell us what you're offering our listeners, our California users, because it's kind
Yeah.
of exciting.
Yep. So for our California users, we are offering a complimentary first visit. And so it's risk-free. Give us a try, book an appointment. If it works, awesome. If not, you've not risked any money. You've risked 20 minutes of your life to learn a little bit. So we'd be delighted to chat with you and see if there's anything that we can do to help you with
And we'll be
whatever.
sending a dedicated email in the next 2 days to all of our California members. So you have all the information and the dates of the offer and exactly how to sign up. And we're really excited about seeing this company grow and hope that you'll start, reaching out across the country. I think it's super
Yes.
important work that you're doing.
And thank you so much for what you do with educating women and how to be the best that they can be. That
Oh,
we do not want to muddle through life. We want to charge through it and love every minute of it.
yeah, and you just realize I think what started this whole community was just this idea that it felt so overwhelming and scary, and there actually are answers. And some of it is scary. I mean, getting older is scary. But there really are a lot of answers and a lot of solutions and a lot of strength in just talking about it and, figuring it out together. So it's been great.
Absolutely.
Yeah.
Yes.
All right. Really, really good to see you. And,
Thank you. So
and
nice
thanks again.
chatting with you.
Yeah,
All
we'll
right.
talk later. Take care.
Okay. Thank you.